starting in the early, we didn't want that first comments anyway. So starting in the early 2000s, just a dramatic rise in both incidence and prevalence. And I'm frequently asked, is that a true increase or are we just diagnosing more? And it's thought to be a true real increase in incidence and prevalence, much like other allergic disorders. Some of the hallmark endoscopic features were really not described prior to the 90s. And so the clinical features I'll go over briefly, but in adults and adolescents, really difficulty swallowing or dysphagia is the rule. If I have a patient who really lacks those symptoms, I'm automatically questioning eosinophilic esophagitis. Highlighted there and in bold, though, is that it's important to ask not just if your patient has dysphagia. First of all, they might not know what you're talking about. And second of all, patients with eosinophilic esophagitis have had the condition for years and years, and there can be a lot of food alteration behaviors, chewing really carefully, drinking water with every meal. In pediatrics, they like to talk about kids who dip every one of their foods in ranch just to help lubricate that food bowl. So in addition to asking about true swallowing dysfunction, ask about altering behaviors. And now, congratulations to us. We're the #1 cause of food impaction and acute food bolus impaction in the U.S. So in children, I'll completely admit that symptoms can be much more non-specific. It's a more challenging specialty in general. Feeding intolerance, failure to thrive, abdominal pain can all be features. And as my colleague will go into, it's associated with other allergic disorders. So how do we diagnose eosinophilic esophagitis? We won't get to this too much, but just to know that this has evolved considerably over the past kind of 5 to 10 years, and where there's a little bit of confusion still, even among my colleagues, despite me standing in front of them multiple times a year, reminding them of how to diagnose it. But essentially, it's a chronic immune antigen-mediated disease. Chronic for me, like I tell my patients, means that kids with eosinophilic esophagitis become adults with eosinophilic esophagitis, adults with adolescents with eosinophilic esophagitis become adults with EOE, and if you treat EOE and then stop treatment, it invariably recurs. And the important ways to diagnose are there needs to be symptoms of esophageal dysfunction. You need to have an eosinophilic infiltrate on esophageal biopsies. So esophageal biopsies are requisite for diagnosis still. And then you need to have absence of other potential causes of esophageal eosinophilia. This is an intentionally blank circle. And you'll note that for those of us who have been doing this for a while, in that circle is not a PPI trial. So importantly, you do not need a PPI trial to diagnose eosinophilic esophagitis anymore. That's a whole talk unto itself. If there's any questions about that, happy to answer during the discussion. So this is what the esophagus looks like in eosinophilic esophagitis. On the right there, you have a normal esophagus. You see your vasculature really well. And then you have obvious abnormalities in the middle and the left with concentric rings, furrows, and absence of those visible vessels. And then on biopsy, you have that dense eosinophilic infiltrate. And then we're not, we haven't had the privilege of having a disease to treat as long as Dr. Click and Debbie have been treating inflammatory bowel disease. So a lot of the natural history is really still being described. But I think one of the important things in how we put it together is that we see EOE as a continuum from starting as inflammation and then progressing to fibrosis. And so when I'm talking to patients, I tell them that it's the chronic inflammatory burden that eventually leads to fibrosis and scarring. And so you start with a normal esophagus. There's an allergic insult leading to inflammation, and then inflammation with progressive fibrosis, the start of esophageal narrowing and stricturing, and then as you progress more and more stricturing and narrowing of the esophagus with therefore symptoms of swallowing dysfunction. And then we think that inflammation leads to fibrosis over time, which may explain different symptoms in the pediatric versus adult populations, and that this diagnostic delay is the dominant cause of stricture formation. And so we know that the longer someone has untreated inflammation, the more likely they are to develop stricturing disease. And so how do we treat EOE? So I've had the 3D slides forever. So we treat eosinophilic esophagitis with drugs, diet, and dilation. And so those are the main treatment modalities. And this is our current treatment algorithm. And so you confirm that a patient has eosinophilic esophagitis, and then you consider one of a multitude of therapeutic options. You can try PPIs, you can try swallowed topical steroids, you can try an elimination diet, and we have our first approved medication for eosinophilic esophagitis, which is dupilumab, where that hasn't even made it into many clinical algorithms yet. That's one of the areas that a multitude of centers are examining. And then you're really evaluating for response in histologic remission, response in symptoms. And then you can go from one treatment modality to another based on response. And then we'll get into chronic therapy in a little bit. I'll mention dilation first, as it's the first of the Ds. In our algorithms, a lot of people advocate for, if you have strictures or narrow caliber esophagus, to really try treatments before endoscopic dilation. I think a lot of us who do a lot of EOE treatment will dilate up front, just because it's the esophageal narrowing that's the dominant cause of symptomatic burden. And so this is what a narrow esophagus in eosinophilic esophagitis looks like. If you open your biopsy forceps, which are about 8 millimeters in diameter, you can see that while a normal esophagus is about 20 millimeters, this esophagus is about 12 to 14, so significantly narrowed. And as a point of interest, I'll frequently see this picture of an esophagus, and it will say no discrete stricture, dilation not performed. And one needs to appreciate that the entire esophagus can be narrowed in eosinophilic esophagitis, so a discrete stricture does not need to be present for there to be significant esophageal narrowing. And so after dilation, you want to see an improvement in esophageal diameter, and you get that with an appropriate mucosal tear, which is our dilation effect. This is the picture that threw people into panic, 10 or 15 years ago when they were dilating eosinophilic esophagitis. The patient then would have chest pain. Understandably, they've got an open wound. You dump tortilla chips or a margarita on top of that, and there's going to be some significant discomfort. And so adverse events were noted left and right. That said, we now have a multitude of studies in both adults, and there's a brilliant pediatric researcher over at Children's who described this in pediatrics also, that dilation, while previously thought to be dangerous in eosinophilic esophagitis, there is not an increased risk of perforation or bleeding compared to indications for conventional dilation. As a little aside, I do a ton of post-procedural chest pain guidance with my patients. I tell them they will have chest pain because I think this might avoid calls to my trainees in the middle of the night. Whether that works or not is a matter you can ask them about. And then we'll get to medications really quickly before I finish up. I think of all medications as options for treatment for eosinophilic esophagitis. Again, we don't use a medication and the response of a medication to make the diagnosis. Rather, we select after joint decision-making with patients about what medication is felt to be most likely to improve symptoms, most likely to achieve remission of inflammation, and most likely to be successful in maintenance. And so for medications, we have our proton pump inhibitors, our topical steroids, and then dupilumab as our lone biologic, though there are a multitude in development. Really briefly about proton pump inhibition in eosinophilic esophagitis. We don't think that this is the mechanism by which it works is acid suppression, but rather an really kind of not well understood anti-inflammatory benefit. But we have about a 42% achieving histologic response, 60 to 70% for our topical corticosteroids. And then really briefly, there is a rationale for maintenance therapy in eosinophilic esophagitis. As I said, it's a chronic disease. Children do not grow out of EOE, and EOE is not yet curable. So because there's near universal recurrence of inflammation and then symptoms, if treatment is stopped, we do recommend continued treatment. These are the studies that kind of advocate for this, where if you have diagnostic delay or the years during which someone has inflammation, they're much more likely to develop fibrotic features, food impactions, and then stenosis. And then lastly, I'll just highlight on our algorithm here, we have a lot of areas where we benefit from our multidisciplinary teams. And so I work with Anjali and Katie a ton. And if you look at all of these areas, elimination diet, the use of dupilumab for EOE and multitude of other allergic disorders, ruling out other allergic disorders that can lead to esophageal inflammation, long-term maintenance therapy, and evaluating effect, and then using elemental diets, we're all a team here. And I think that's one of the big benefits. It's not, EOE is not a disease state that belongs to one specialty, but rather one in which we benefit from a multitude of opinions. So with that, I'll cede to my next colleague speaking, and looking forward to the conversation.
All right, next we're going to hear from Dr. Kalra. She's an allergy and immunologist here and happens to be married to one of our course directors, Dr. Avash Kalra, but she's the better half for sure. So welcome.
All right, well, thank you so much for having me. I have no disclosures. My learning objectives today include to hear about the pathophysiology, diagnosis, and treatment options for EOE from the allergist perspective. We'll review the ins and outs of dupilumab therapy. Oops, went too far. We'll also review food elimination from the lens of the allergist, and I'll finish up by talking about the comorbid allergic conditions that can have effect on EOE disease progression and management. So as Dr. Menard-Ketcher nicely discussed previously to my talk, EOE is a chronic allergen-driven type 2 inflammatory disease of the esophagus, which I should stop touching that, which disease progression can lead to tissue remodeling, hypertrophy, narrowing, and fibrosis. And again, early diagnosis is key for preventing possible irreversible damage. The pathophysiology of EOE is complex. Again, it's Th2 mediated, characterized by the infiltration of eosinophils into the esophagus. It's triggered by allergen exposure, and activated lymphocytes increase tissue levels of Th2 cytokines, interleukins 4, 5, and 13. The number of newly diagnosing patients is increasing, as Dr. Menard-Ketcher mentioned. Currently, the prevalence is around 56.7 per 100,000 persons in the US. And delayed diagnosis is a serious issue. So mean years of delay from onset of first signs and symptoms of EOE to diagnosis in adults is 11.1 years. And for children and adolescents, it's 4.3 years. What I will focus on is that many patients with EOE have comorbid atopic illnesses. Approximately 80% of kids have an atopic condition, and approximately 50 to 70% of adults have an atopic condition. And this includes IgE-mediated food allergy, allergic rhinitis, atopic dermatitis, asthma, chronic spontaneous urticaria, and allergic conjunctivitis. I will be discussing each of these conditions briefly in a few slides. But again, the approach to EOE management is going to include medical therapy, dilation, and dietary therapy. For medical therapy, again, as was discussed previously, we have PPIs. Topical corticosteroids, as well as dupilumab. And with regards to dietary therapy, I will discuss this briefly, but we have empiric elimination as well as elemental formula in children. And then, of course, there's dilation. Treatment choice is really driven by patient preference, as well as clinical features and cost. So dupilumab for EOE is something I do want to focus on. Dupilumab is a humanized monoclonal antibody that inhibits interleukin 4 and 13 by blocking the IL-4R receptor alpha subunit. It's approved for patients 12 months and older for EOE, but it is approved for numerous other atopic conditions, and that includes moderate to severe atopic dermatitis, moderate to severe persistent asthma, chronic rhinosinusitis with nasal polyposis, as well as prurigo nodularis. Dosing for patients 12 and older or 40 kilograms and older over is 300 milligrams weekly. And the side effect profile overall, dupilumab is very well tolerated. Conjunctivitis is one of the major side effects that we tend to see. This is treatable. Eosinophilia as well can be noted. Now, this is a normal response to dupilumab. So initially, you'll see a rise in eosinophils and then a reduction after therapy is initiated. But however, some people will have hypereosinophilia. And so I do in my practice check a CBC with differential about 6 to 12 months after initiation of dupilumab. We do recommend avoidance of live vaccines, however, practice does vary. These are the phase 3 results for dupilumab. The two primary endpoints were histologic remission and a change in mean dysphagia symptoms questionnaire score. I apologize, this is moving so much, but I must be doing something to do this. So anyway, the two endpoints I want to talk about for dupilumab weekly dosing as well as dupilumab every 2-week dosing resulted in histologic remission. However, the reason why dupilumab is approved for weekly injection is because only dupilumab weekly improved the DSQ score. I want to make a point here that for patients who have other atopic conditions, dupilumab is approved every 2 weeks. Now, this does not necessarily mean you need to continue weekly dosing for EOE indefinitely. For many other atopic conditions, we do space out dosing. A weekly injection can be burdensome, but also the cost of dupilumab is very high. So this is something that can be considered. This is a lovely article by Seema Aceves and Evan Dellin. This is looking at patients who would be good candidates for dupilumab. And as I mentioned, of course, patients who have other atopic conditions would be excellent candidates. Patients who have a strong preference for avoidance of dietary therapy, as well as to avoid systemic steroids and, of course, topical steroids, and patients who are difficult to treat overall. Briefly regarding food elimination. Okay, so briefly with regards to food elimination, a 1 food elimination diet with cow's milk was found to be not superior to a 6 food elimination diet. I do want to spend a moment on skin prick testing. So skin prick testing for food elimination is not recommended. So EOE is not an IgE-mediated disease. This is a food allergic condition, but skin prick testing is evaluating for IgE-mediated food allergy. It can be highly misleading. We have a 30% false positive rate for food skin testing, and this can lead to unnecessary anxiety and food avoidance. So practical considerations for food elimination from the allergist perspective. So in the pediatric population, one thing to consider is that patients undergoing food elimination may be at risk for developing sensitization or IgE-mediated food allergies. So when you're a child and you take out a food from the diet, there is risk for development, especially in these atopic children, for developing an IgE-mediated food allergy. This is most commonly seen with peanut and tree nut. And because peanut and tree nut are not common causes of EOE, this is something to really keep in mind. In the adult patient population, food elimination does not place you at increased risk for food allergy. So there are therapies under investigation. I do want to just briefly talk about the interleukin-5 therapies. Both mepolizumab and benralizumab did not meet the one of the primary endpoints, which is improvement in the DSQ score. They did result in histologic improvement. Tezepelumab is an anti-TSLP that is undergoing evaluation, and I do think will be more promising. That works further upstream than the anti-IL-5s, and so that's potentially promising. So in monitoring patients with EOE, as Dr. Menard-Ketcher mentioned, in general, endoscopy 8 to 12 weeks after induction treatment or major change in treatment will be recommended. But what I want to focus the last few minutes on are atopic comorbidities in patients with EOE. So I think in general, most patients with EOE or many patients with EOE will have comorbid food allergic disorders. Because EOE is not an immediate hypersensitivity or IgE-mediated food allergy, patients with EOE cannot predictably identify their trigger. However, many patients do have IgE-mediated food allergy and conditions such as pollen food allergy syndrome. And so many patients with EOE will think that certain foods are are triggering their underlying inflammation. However, it's important to be aware of these other food allergic disorders so we can counsel our patients. So IgE-mediated food allergy occurs generally within 30 minutes, maximum of 2 hours following ingestion. Signs and symptoms, of course, include hives, vomiting, diarrhea, wheezing, hypotension. Typically, these food allergies occur, onset is in early to late childhood. And diagnosis is primarily based on clinical history. Skin prick testing can aid in the diagnosis, and an oral food challenge is gold standard. Our major food allergens include peanut, tree nut, sesame, cow's milk, egg, wheat, fish, shellfish, and fish. Oral immunotherapy is something we should all be aware of because oral immunotherapy can result in eosinophilic esophagitis. So OIT is the introduction and incremental increase of an allergenic protein in the diet. And we do this for children. We do this in adults, but the efficacy is far greater in children. There is a 3 to 10% risk of developing eosinophilic esophagitis in patients on OIT. When we do remove the food from the diet, usually this does resolve, but this is something to be aware of in your practice. Just to briefly mention omalizumab, anti-IgE, this was very recently approved for IgE-mediated food allergy. And your patients who have eosinophilic esophagitis as well as IgE-mediated food allergy, this could be a potential adjunct therapy. Omalizumab is not effective for EOE, but this raises the threshold for reaction for anaphylaxis. I do want to spend a moment on pollen food allergy syndrome. So many patients with eosinophilic esophagitis have PFAS. It's also called oral allergy syndrome. This occurs due to cross-reactivity between pollens and fresh fruits and vegetables. So classically, birch, trees pollinate in the springtime. Birch cross-reacts with many fresh fruits and vegetables, including apples, peaches. Patients will have discomfort, irritation, itching of the ears, of the mouth, swelling of the mouth. Oftentimes, this can be misconstrued as a flare of eosinophilic esophagitis. What is important to understand about pollen food allergy syndrome is this generally will not lead to anaphylaxis, and these patients can safely consume these foods by cooking them because those proteins are denatured. And of course, environmental allergy, highly comorbid with eosinophilic esophagitis, both seasonal and perennial allergic rhinitis, allergic conjunctivitis. And there is some data to suggest that some patients may experience worsening EOE during certain seasons in conjunction with allergic sensitization. So our first line treatment is going to be intranasal corticosteroid, adding on as an adjunct a non-sedating oral antihistamine or azolastine, which is a nasal spray available over the counter. I do want to make another point here about sublingual immunotherapy. We have 2 types of immunotherapy for allergen immunotherapy. There are allergy shots, which are also subcutaneous immunotherapy. And then there's sublingual immunotherapy, which there's FDA-approved tablets that you put under the tongue. And then there are allergy drops, which are not FDA-approved. Any of these sublingual immunotherapies can increase the risk for eosinophilic esophagitis. Asthma, of course, we do see in our EOE patients. Dupilumab is approved for moderate to severe persistent eosinophilic asthma and chronic rhinosinusitis with nasal polyposis over the age of 6. And finally, atopic dermatitis has an indication for dupilumab down to 6 months of age. And so can be helpful in these very young patients who are having failure to thrive due to eosinophilic esophagitis. So just to wrap up, what's the role of the allergist in EOE management? Again, as Dr. Menard-Ketcher mentioned, we really take a multidisciplinary approach to EOE. Many EOE patients have significant atopic comorbidities. We can certainly help with the approval of biologics for EOE, as well as manage those comorbid conditions. And we can always discuss therapies with our patients and give our perspective on dietary therapy and medical therapy. Thank you so much.
Our last speaker will be Ms. Holmes. She's a registered dietitian in our GI department, an incredible resource and colleague. So welcome to the stage, Ms. Holmes.
Right. Hello, everyone. Thank you so much, course directors, for inviting me to speak today, as well as Brooklyn. It's always great to have dietitians involved, since, of course, we all eat, our patients eat, and it's very important to have this conversation about diet and nutrition therapy, especially with the eosinophilic esophagitis. All right. So I have no disclosures today. And the objectives are to describe nutrition therapy options for the treatment of EOE, compare advantages and disadvantages for empiric elimination diets, review patient selection considerations for EOE dietary therapy. All right. So as we're all probably aware, there are several options when a patient is considering diet therapy for treatment of EOE. The first one being the one food elimination, which includes dairy. And we have gotten questions, does this include goat's milk, sheep milk, goat cheese? Yes, any dairy product that comes from a mammal, we need to avoid in the diet. The two food elimination, of course, is dairy and wheat. The four food is dairy, wheat, egg, and soy. The six food is dairy, wheat, egg, soy, peanuts, tree nuts, and fish and shellfish. So there's quite a few eliminations there if they choose to proceed with a six food. So we do have options in regard to the approach we take between a step down versus a step up. The step down approach, of course, is starting with either a six food elimination or a four food elimination. And of course, these foods are taken out of the diet for 6 to 8 weeks, and then they go in for another scope. If those eosinophils are higher than 15, then we should consider non-dietary therapy at that point if they have chosen to proceed with a six food elimination diet to start. So that's the one advantage I would say, is at least we know pretty quickly. We're not going through many different scopes in order to find out, are they even a responder to diet therapy? So the one or two food elimination, so that's our step up approach. So if they start with the one food, start with just eliminating dairy, again, take it out of the diet for 6 to 8 weeks, have that scope. If the eosinophils are greater than 15, we need to step it up to a two food, and so on, step up to a four food, step up to a six food. So it can, of course, require multiple scopes, but there is a possibility that dairy is their trigger, and they go through the one endoscopy, they have the, response, and we're able to stop, further treatment right there. So that is a benefit. And then, of course, this is a kind of busy graph, but it reviews what we just kind of went over, but the process is pretty intense. So I don't want patients coming in and thinking it's a quick 2-month process and they're going to know what their food trigger is. It can take 2 to 3 years, depending on how many scopes they have to take, what their response is when they're taking these foods out. Were they compliant with the diet? There's many, many factors involved. So some patients, of course, choose to go the route of medication as opposed to continuing on with multiple scopes and multiple food eliminations. Here's a good summary of, again, multiple studies that were combined, and we were able to kind of get a pooled response rate for, the six food elimination, where we have 40 to 73% response. The pros, it is the most well-studied of the empiric elimination diets and the highest histologic remission rate. But again, it's the most restrictive. So taking out all those foods, it's quite a lot. There are a high number of endoscopies involved. Cost is a consideration, and adherence to an elimination diet. So it definitely takes a very motivated patient in order to go through the process. As you can see here, the four food elimination had a pooled response rate of 41 to 60%. Again, it is less restrictive. There is a greater diet variety. It may shorten the diagnostic process. And the cons would be a possible lower remission rate. Cost and adherence are also to be considered. The two food elimination with a 43% pooled response rate, of course, it's even less restrictive, avoiding unnecessary restriction and shorter diagnostic process, and also impact on quality of life. But there is a possible lower remission rate, and impact on quality of life needs to be considered. And then with the one food, it's pretty similar. So 34 to 65% response rate compared to the six food of 40 to 73% response rate. Again, it is the least restrictive diet. We avoid the unnecessary restrictions. We have a shortened diagnostic process, hopefully, if they respond, and then less endoscopies and impact on quality of life. So those are, some overviews of pros and cons. And then which approach do we choose? Does the patient want to start with the step down approach or a step up approach? So the six food elimination diet is an effective treatment approach for EOE, but it can be challenging and affect a patient's quality of life. The one food has similar clinical response rates to a 6-food elimination diet. In a recent systematic review and meta-analysis that compared 34 studies and 1,762 patients. So you can see the efficacy rate of the 6-food being at 61.3, the one food being at 51.4%, but the clinical response was 92.8% and then 87.1% for the one food. So majority of patients I've seen lately are much more comfortable starting with the 1 or 2 food as opposed to starting with the 6 food. So just want to mention that. I did have a patient come into our clinic who was recently diagnosed with EOE. Her eosinophil count on her EGD was 24 eosinophils in the upper and 52 in the lower. She was treated with 40 milligrams of omeprazole BID. After a repeat EGD, her eosinophil count improved to 2 eosinophils per high power field. She wanted to avoid medication and was interested in a 2-food elimination diet. She met with a dietitian for further guidance. She stopped her PPI and proceeded with the dairy and wheat elimination. She removed these foods from her diet and had a repeat EGD in 8 weeks that showed 7 eosinophils per high power field. She added wheat back into her diet and had a repeat EGD, and that showed 7 eosinophils in the high power field, in the upper and 2 in the lower. So dairy was determined to be her trigger food. So this was a really nice case where if we had started with a 1 food, just done a dairy elimination, she would have been able to liberalize her diet, avoid unnecessary restriction, and have 1 less EGD. But she was very happy to at least determine that dairy was her trigger. She did mention how difficult the whole process was. So again, that's always something to consider. And then when we're looking at patient selection considerations for diet therapy, we do need a highly motivated patient in order to undergo the diet therapy. Typically, it's driven by not wanting to take medications, a patient's ability to adhere to an elimination diet, the patient's lifestyle, if they frequently travel, if they dine out often, their ability to shop and prepare meals, and also financial constraints need to be considered. If a patient has a history of food restriction or ARFID, eating disorders or disordered eating behaviors, again, really should not proceed with the elimination diet unless they're, psychiatrists, their therapy team, everybody is in agreement that, yes, we can trial an elimination diet, but I would prefer medication treatment. Those with multiple food allergies or intolerances, patients who are malnourished or at risk for malnutrition, we do not want to restrict their diet. Patients with significant mental health conditions. Again, there can be diet-related anxiety involved with being very concerned when they're potential exposure to a food that they're, really working hard to eliminate. And then overall nutrition recommendations, if at all possible, to consult a registered dietitian. If your patient is interested in pursuing an EOE elimination diet, we do review a lot of different resources for patients. And, again, they get some information, of course, but to really have that full dedicated time to spend with a registered dietitian to review all, the options that are out there for their treatment and really helping them through this process. It is so important. I always like to focus on the nutrient-dense foods that are safe for all elimination diets. So even if they're doing a 6-food, they still can have fruits and vegetables, corn and corn products, peas and pea protein, potatoes and sweet potatoes, rice, quinoa, gluten-free oats, meat, poultry, seeds, sunflower seed butter, beans, lentils, and coconut-based dairy products, just to name a few. So again, it's not, they have to take everything out of their diet. And that's, the big question we get, well, what can I eat? So it's always good to focus on, natural foods that they can have. If a patient is losing weight or there's concern for inadequate nutrition, if they're undergoing the elimination diet, we can definitely include oral nutrition supplement drinks. One of them is called OWEN, stands for Only What You Need. Kate Farms is all allergen free. There's a Ripple vegan protein shake out there, and Orgain plant-based protein shakes are definitely options for your patients. We also highly recommend and really, enforce that they have to be reading ingredient labels on all packaged foods. I had a patient undergoing an elimination diet. He was able to add fish back into his diet, but he had started with a 6-food and was eating tuna fish that contained soy. So it was just a struggle to enforce that he has got to be paying very, very close attention to all packaged foods and what's actually in there. We also advise limiting or avoiding travel and eating out when following an elimination diet to reduce the risk of cross-contamination or accidental exposure. So these are all important, things to consider. We have some resources here. So we always review the foodallergy.org website with our patients that are undergoing the elimination. There's a very extensive list of all foods to avoid. A lot of great information on their website. Allergy Awesomeness, they have a lot of recipes and just really, excellent resources as well for your patients. And then, of course, the CEGIR, they have an extensive patient education handout that's about 48 to 50 pages long. So it really goes through each diet if they were to do a 1 food, 2 food, foods they can have, foods they need to avoid, and just a lot of great resources in their handouts as well. And then, of course, finding a GI specialist as a dietitian can be challenging. So we definitely want you to look into IFFGD. So they have a dietitian listing. And then, of course, through the AGA, there's also a dietitian listing. So just want to support your patients as best we can, but I highly recommend referral to a registered dietitian. All right. Thank you very much.
All right. Do we have any questions to start for our amazing panel? Thank you so much to all three of you. Got Christy one in the back there. No mic. We're coming to you with a mic. Okay.
I'm going to repeat the question. So it was, is
Okay.
there a role?
Is there, yes, sorry. Is there a role of doing skin allergy testing or doing IgE levels to identify which potential triggers instead of doing an elimination right off the bat?
Yeah, so EOE is not, so when we're doing skin testing and serum specific IgE testing, it's really looking for immediate hypersensitivity for IgE mediated food allergy. So because EOE is not an IgE mediated disease, we do not recommend that testing. And there is somewhere around a 30% false positive rate with that type of testing, which can lead to a lot of unnecessary avoidance. So it can be problematic.
Yes, so the question was, does twice daily PPI dosing improve response rate? And that actually was recently looked at. There was a small clinical trial comparing daily omeprazole to twice daily, and there was a slight increase in response rate with twice daily. Selfishly, like if I'm putting someone on a twice daily therapy, then, I really start thinking about whether I would just want them on topical steroids with a better response rate to begin with. It depends a little if they have contaminants, reflux symptoms. That's a patient I'll choose to do on PPI first. And then I get the inevitable, what about my dementia risk and stroke risk and fracture risk and death risk and spontaneous combustion risk? Yeah, so when are we using dupilumab? So I think that's a great question. I think some of the things that Anjali and I highlighted. I think an ideal patient is someone with pretty significant eosinophilic esophagitis, and someone who has troublesome concomitant other allergic disorders. I think that's the ideal patient. I have used it up front as a first-line treatment as well. I think in some of my kind of younger patients who have a lot of trouble with adherence, the weekly dosing is actually pretty convenient. Anjali was complaining about weekly versus every other week. When you're talking about twice a day to an adolescent in college, that's like, that's virtually impossible. So that's one of the benefits. So I think it's And there is some data about fibrosis reversal. So they did have reversal of some of the fibrotic features on eosinophilic esophagitis in the dupilumab trial. So my more severe patients with narrow caliber esophagus, using something like that up front is something that I've been doing as well. But long story is that there's not really a good algorithm for where to put it in. Yeah, they put on the kind of some of the recent reviews about what other centers are doing.
We have a couple of poll everywhere questions. Does EOE increase risk for esophageal cancer? If not, why not, given the association with chronic inflammation and fibrosis?
It's like one of my favorite parts of my spiel to my UE patients. I'm basically like, this is a chronic disease. No one wants a chronic inflammatory disease, but if you have to choose one, it's not the worst one to have. And there is no risk of Barrett's esophagus that we know of. There's no risk of esophageal cancer that we know of. Why the chronic inflammatory pathway is different, the inflammation in reflux disease that can very rarely lead to Barrett's esophagus and esophageal cancer, but we don't really know. But to date, the natural history studies that we have, there's no risk of esophageal cancer. Maybe for adenocarcinoma, it might be that there's just not the intestinal metaplasia that we see with reflux disease, which is the big driver of dysplasia. But for now, no.
And just to piggyback on that, the association between EOE and GERD.
Yeah, and so I think this is an interesting, I talk about kind of overlapping Venn diagrams, right? There's a lot of GERD and there's more and more EOE. There's going to be some people who truly have both. And so I think that's an ideal candidate for starting with PPIs first. And then some of the more interesting parts is, right, when you have pathologic reflux disease, you're decreasing that esophageal barrier, potentially increasing the amount of allergen exposure to the subepithelial space. And so can reflux worsen EOE? And then there's also data that EOE can potentially worsen reflux disease because one, you have kind of increased esophageal stiffness, impaired motility of the esophagus has been documented in eosinophilic esophagitis, which can then impair clearance rates of reflux events. So that's the association really briefly.
All right, and then last question here. What age do we see EOE being diagnosed?
All the time.
I mean, I think EOE can be EOE can be diagnosed at any age. I think the point is that, there's a significant delay in diagnosis. So as I mentioned, 11 years for adults and about 4 years for kids. There is, again, as Dr. Menard-Ketcher mentioned, there's a big difference between how kids present and how adults present. And for younger children, it's often, failure to thrive. And so this is something we certainly consider, food avoidance, things like that. It's a lot, I would say, easier to get a history from an adult. But I don't think there's any particular age where we are seeing it diagnosed.
Yeah, I would say we see it in all ages, certainly in the pediatric group, and in the adult setting, we used to say you don't see it in people who are in their 5th or 6th decade of life. Now we're seeing people who probably had it for 30, 40 years or just presenting now. So I don't think that there's an age cutoff at all. And one of the anecdotes I like to give about the delay in diagnosis is that one of my favorite and most frequent clinical settings is I'll have someone presenting, for the first time, and you ask them how long have they had food impactions, and they'll be like, forever. And I'll ask them, well, why do they coming in now? And it's because they have a new partner who's like, this is not normal. Like, you should not be getting up from the table and going to regurgitate into the toilet. Like, that's not normal behavior, but they've been doing it for 30 years. So it's a good time.
Well, thank you so much to our speakers. Thank you to the audience for the questions you submitted.
This is the last session. Obviously, the crowd's a little lighter than it was at 8 a.m. today. See several people at the back. Would just ask if you can or would like to, feel free to move up to the front of the room. So for our final session, which is going to be a debate on pretty interesting topic, exciting topic. And I anticipate that in future years at this conference and really any GI conference, there'll be more and more talks on the topic of artificial intelligence in general, or AI. So in this particular debate, we are going to be pitting Dr. Thomas Enck, a third-year GI fellow, and also one of our chief GI fellows, against Dr. Alex Torres, who's a GI fellow here with us as well. So they hopefully have their boxing gloves ready. They were talking about whether there were gloves back there or not. And we're going to talk about the use of AI during colonoscopy. So the format is basically that each of them will present their sides of the argument. There'll be opportunity for cross-examination, but we are going to start with this question. And we'll present this question at the end to see if there are changes based on what you hear. So the question is, how often do you think AI, artificial intelligence, should be used during colonoscopy? And you can see the choices there. We'll give this just a minute as folks get settled in with their drinks and desserts. Spring rolls, artichoke balls. Artichoke, yeah, I think. Not everyone knows that reference. Fellows don't. Okay, so looks like about, okay, we'll stop it there. 55% say regularly, 9% infrequently, and 36% whenever possible / always. Okay. All right, so we'll bring up the first presentation. So Dr. Torres is going to present AI in colonoscopy, the next frontier. I'll have him tell you which side of the argument he's on, and we'll go from there.
Thank you, Dr. Kalra. Obviously, I am debating on the in favor side of AI in colonoscopy. I'm sure at this point, everyone is familiar with it. In fact, I'm sure that a number of you have had experience using it already, and maybe already advocates, as the poll might suggest. And there, I'm sure, are a number of skeptics among you. And I hope for the non-believers that after this presentation, you'll walk away armed with data and information to help change your practice, and believe that using AI can prevent interval cancers. And for the believers, have more data armed to, continue your practice. All right. Is this just a click? This looks different here. There. But it's not presenter mode here. This is like moving on. So.
Can we put it back on presenter mode? Thanks.
This doesn't count for my time. Cool. All right. So first off, I'll start off with a vision of the future. Let me know if this kind of rings true for you. Well, we will make large reductions in the incidence of colorectal cancer over the next decade with only small and incremental improvements in practice and technology. Sound believable? I don't really believe that either. I don't think that there are going to be only small and incremental improvements. I think AI is a revolution and a major structure and shift in the way that we practice and kind of interact with the world around us today, not just in healthcare, but in everything. And so with that, I'd kind of set the stage with this quote by FDR that says, "The only limit to our realization of tomorrow will be our doubts of today." So with that, let's talk about what we would like to see from AI. The perfect colonoscopy does not exist, but could it? What would that even look like? Here we have a few different kind of categories of things that I think might be included in a perfect colonoscopy. No missed lesions, negative polypectomy margins, real-time lesion analysis, real-time pathology, Decrease procedural time as a result of efficiencies, minimize sedation accomplished as a result of improved efficiency, minimize looping. There are a number of AI tools that are aiming to kind of help you track your scope position within the colon to help target that. Automated procedure reporting, never having to write a procedure report again. Wouldn't that be nice? Automated repeat colonoscopy ordering so that you know your patient is covered when the next colonoscopy needs to be ordered, and it's not just kind of a missed to follow up. Automated quality reporting, ADR, which is notably hard to track, or new and better AI-enabled quality metrics that we can track automatically across the board consistently for everyone. Automated educational tools and training. And this is just a few. I'm sure for a number of you, the perfect colonoscopy will look different than this, and you could add or take away things, but this is just an example. Well, let's talk about what exists. Computer-aided detection. So that's CAD-E for short. And essentially it's AI that rapidly analyzes real-time video to spot suspicious lesions. This is the type of AI that a number of you are already used to and have already interacted with in our various settings. It improves adenoma detection rate. Can you guys spot the lesions? It's not that easy, right? It's easy when adenomas are just kind of jumping out at you, but these are, a lot more camouflaged. And when you're doing a withdrawal and it's already been a little bit of a long procedure, do you trust yourself to find this every time? Okay, I'm sure a number of you are expert endoscopists, but how about your colleague? You trust them, the non-expert endoscopist, to find this every time? What if you had AI over your shoulder, an expert endoscopist that has actually better detection rates than expert endoscopists with you all the time? AI doesn't get tired, it doesn't get distracted. It's always squinting to see every single possible lesion that could be there to bring it to your attention and help prevent an interval cancer. Some data to support this. So I'll start off with, of the various meta-analyses that exist, of the least favorable of them. So this was one that was just published early in 2024. Looked at a number of articles, 1,314 of them. At the end of the day, only 12 met inclusion criteria, notably did not include RCTs. And there was a big difference between prospective and retrospective studies. They themselves note that within the prospective studies, the ADR was significantly higher, about 2%. In the retrospective studies, that was not seen as well. Well, importantly, retrospective studies are notably a poorer study design and can introduce bias in a topic that's already hard to study without bias, even in prospective analyses. And you might say, all right, well, 2%. What is the clinical significance of 2%? That doesn't sound like all that much to change my practice. Well, we know from a 2014 New England Journal of Medicine study that just a 1% ADR difference improves interval cancer rates, or decreases them rather, by 3%, and interval fatal cancer rates by 5%. So that's a 6 or 10% difference respectively. And just to kind of put the numbers into a different scenario, let's say you were doing 50 screening colons a week, 16 procedures a day, 3 days a week of scoping. It's not unreasonable. Sure, maybe they're not all screenings, but just as an example. The number needed to treat on a 2% ADR difference is 50. That means every week there's potentially an adenoma that you missed. That means 48 if you took 4 weeks of vacation that year. 48 adenomas in 48 different patients that are just walking around there that you didn't spot, and potentially they're going to get a 10-year interval when they shouldn't have, or it could have been taken out and they're walking around with an adenoma growing. That interval cancer rate is going up for those patients. You have to ask yourself, how much is the limit of acceptable? How many interval cancers more are you going to tolerate as an endoscopist before you say, that's too much for me? Is 48 a year too much for you? These are preventable. Another more favorable study recently done. This was published in the Annals of Internal Medicine in 2023. From 2019 to 2023, this one included 21 different studies, included RCTs. Their adenoma detection rates were even higher. So if you can see here, we're no longer talking about 2%. We're talking about 8%. And you can even see that the adenomas per colonoscopy is also higher. Importantly, this is a forest plot of adenomas per colonoscopy. And even in the studies that don't reach significance, because you can see their standard of error bars touch that 0, everything to the right is showing that there's more adenomas per colonoscopy being found with AI. I think it's pretty easy to see, even for a non-scientist, that it looks like there is a big signal and data point to more adenomas being found with AI than without it. Additionally, this is a study out of Northwestern that was just published, I believe in April of this year. Single academic center, very similar to ours. They had almost 7,500 screening or surveillance colonoscopies. I put this study in because it kind of outlined a number of different and interesting points. Number one is that they kind of stratified between high AI users and low AI users or adopters. Even the ones that didn't use AI that often, they still studied them. And if you see on the bottom of this table, that's looking at the low AI users, and they actually didn't experience the benefit. Versus the people that were high adopters, and there were about 10 of them. There were 27 endoscopists, and only 5 of them didn't answer the study to be able to be put in these bottom 2 boxes. But of the 10, you can see the ADRs that are highlighted in the top one, 37 in non-users or in not available versus 45. That's 8% difference. That is statistically significant and quite a difference. Notably, they also looked at serrated detection rate, and that was also better with AI. And those are the polyps that are really going to make a difference, where they're more camouflaged, harder to spot, and make up to 1/3 of actual colorectal cancers. And so I think notably here, what they talk about is if you're not using it frequently and are not an adopter and are not at your own kind of essence buying into this, you're not going to get the benefit that it can offer you. And that might be why there has been a lot of variability in the data behind. They also looked at why people don't like AI. And it seemed to be that there was this perception of high false positives and that it wasn't actually significantly improving their polyp detection rate. But this study suggests that maybe what people think are false positives aren't so false, and that you're just ignoring actual polyps that should have been taken out. Then we have computer-aided diagnosis. This is a kind of new area, and I think for our team, something that a lot of people may be familiar with in concept, certainly not in practice. This is now commercially available as of May of this year, presented and showcased at DDW. And essentially what it's doing is it's not just spotting the adenomas for you or the polyps, but it's telling you, is this a hyperplastic polyp or is this an actual adenoma? In the future, ideally, it should be able to further distinguish if this is a serrated adenoma or if this is a tubular villus or just a villus, and kind of help kind of stratify for advanced adenomas. But already, if you look at this bottom left picture, I'm sure among the expert endoscopists, they might say, oh, that's, I would have thought that was a hyperplastic polyp too. It's white and pillowy. But I looked at it, I wasn't so sure that I wouldn't have just taken that out. But the sensitivity and specificity of this CADX software is 97%, I think it's like 97.9 in trainees and 99% in expert endoscopists. And they compared that against non-CADX use. And in trainees, that was about 78%. They got the polyp type right. And in expert endoscopists was 92%. That's great for expert endoscopists, but we can still do better than that. We can do 99%. And so what if you had this over your shoulder? Also, we have sizing. What if we could more standardly assess the size of polyps? This is also available commercially now to be able to automatically assess the size. They introduced a laser, as you can see there, that tells the scope in the software how far away the scope is from the lesion and be able to create a scale. On the bottom here, this is a different technology not currently available, but they use the size of the biopsy forceps to be able to assess it. And it says, oh, that's a 10 millimeter polyp. This affects our guidelines. If we say that someone has an 11 millimeter polyp, that changes where we put them in terms of our surveillance guidelines versus we say it's a 9 millimeter polyp. And there has been a lot of study into the inter-observer variability in this and the effects that it can have on our patients. Other quality improvement tools, blind spot monitoring. You can have a withdrawal speedometer. Kind of sounds cool. This is what it might look like on the top right where the star is. That right here, they're looking at this polyp so it's not moving, but it's literally got a speedometer to tell you where you are, and it will tell you if you're withdrawing too fast. There's a lot of different kind of quality of life potential applications that can really kind of make efficiencies or improve quality. Potential for improved efficiency. While this is not currently the status quo of where the technology is, and the data has not supported this yet, it's not kind of hard to believe a world where additional advancements and release of additional diagnostic or automation tools may offer improved procedural efficiencies. Things like further improvement with CADX can, in the future, support kind of diagnose and leave strategies because now you know that's hyperplastic, don't need to take it out. And, sometimes we see a lot of hyperplastic polyps and say, man, I don't know, I just got to test myself. I'm going to take one for the road, but all of that is procedural time. Or we already know that this is an adenoma, but once it's able to say this is not a tubulovillus or villus, there's other strategies where it is resect and forget. You don't need to take it back for pathology. You can save on that cost. You can save on the, I don't know if I got it in the tube. Do you have a trap on? It's just stuck in here. Can I have some flush? All of that is gone. Potential procedural efficiencies that can be gained from this. And then obviously you can imagine a world where if you didn't have to write a procedure note and you could spend the time talking to your patient more calmly, or just having a little bit more time to breathe in between procedures and not saying like, man, I just got to get this because the rooms are now turning around in 5 minutes. Very important. Plus, what's a colonoscopy? If you did all of that work and then you didn't write a good report for yourself or for your colleagues in the future. We've all seen that, I'm sure we all think of ourselves as good authors, but I'm sure that we've also all seen a number of procedure notes where like, man, I really don't know what they did. I don't know what they found. I don't know if I trust this. With AI, all of that can be standardized. As an education tool, I would say that with all of these data, for those trainees of us, this is kind of always having the best attending available all the time that's never distracted, and can help support new faculty in early practice or older faculty to kind of test themselves and see where their metrics are. Maybe you're not doing as well as you actually thought, or maybe you're above the curve, and that could be something that could be tracked. There's a lot of different metrics that we can kind of implement, and a lot of new things that we're not currently tracking because we don't have the technology to do so, that would be available and easily done and automatically done with AI. Then you finally have the business case, because if it doesn't make sense, it doesn't make dollars. Or if it doesn't make dollars, it doesn't make sense, excuse me. I would say that all of these different things, that AI is relatively inexpensive to implement on a per case basis. And all of these efficiencies in terms of procedural efficiency, that is money. If you talk to anyone that runs an ASC, they'll tell you that there are a number of fixed costs, and that the higher amount of procedures that they can do in a day, the lower the cost of the procedures are, and that is improved profits for those facilities. Additionally, by saving and implementing some of these resect and forget strategies in the future, or diagnose and leave, you can also save pathology costs and these things for the patients and the healthcare system overall. It's also going to, by improving the quality, going to help create a further economic moat against other screening strategies like that of fecal DNA testing, or that was newly approved kind of serum colorectal cancer testing that we're going to have to compete with and justify why patients should still get a colonoscopy to screen for colon cancer instead of these things done. And so I'll leave you with this. It's not the strongest species that survives, nor the most intelligent, but the most responsive to change. Change is hard. I'll take you with an adaptation from the Harvard Business Review and say that AI is not going to replace doctors. Doctors with AI will replace those without. And so at the end here, where do we finish off? What's the state of AI today? We have the current / most important kind of advancements in this kind of upper left box, that we already have the technology that is improving ADR. We have lower miss rates. We have real-time lesion analysis. In time, we will get pathology. We also have all of these other things that are in development, and these things together will increase patient-centered care, cost-effective care, evidence-based care, expert-level care, and standardization, and help push us closer to a perfect colonoscopy.
What we're going to do is we're going to go straight to the con, and then you'll save your points for each other with the rebuttal after that. So Dr. is going to present next the con side using AI in colonoscopy.
Two minutes. All right. Looks like I don't have the updated one. It's okay. Well, thanks for joining us, and thanks for sticking around for the last talk of the day. So I'm going to be giving my lecture, AI in colonoscopy. Is it time to pump the brakes? And I'll kind of blow through this, but there's been an explosion in terms of the number of publications around artificial intelligence in GI in just the past few years. And even just from the onset of this kind of exponential increase in 2016, about 6 years later, we have our first FDA-approved CAD-E system within the United States. And this is, some might say, a little too fast, and maybe we just need to slow things down and really have a better understanding of what's actually going on here. So in this talk, I'm going to argue that the current artificial intelligence tools to assist in colonoscopies for colorectal cancer screening should not be adopted into widespread clinical practice at this time. So as Dr. Torres kind of outlined, the current landscape of artificial intelligence tools within the United States, I think we're most familiar with CAD-E, or that extra set of eyes, but there's other things like CAD-X, which aid in optical diagnosis, as well as some emerging tools, and I'll emphasize emerging tools that help with things like quality assessment and also some different risk assessment and stratification tools. At least when I looked at the FDA website yesterday, I only found that the only FDA-approved commercially available products within the United States are CAD-E devices, though there are some CAD-X sites that are available in other countries, but I might be wrong with that. And focusing on CAD-E, this kind of is, like I said, that extra pair of eyes, and they flag those polypoid lesions with this bounding box. But I would say, they're not specific for just polyps. It's not uncommon for them to pick up other things like mucosal folds, mucus, other debris within the colon, which kind of prompt these false positives that drive some endoscopists mad. And as Dr. Torres has kind of pointed out, there's numerous clinical trials published in high-tier journals that have shown a pretty substantial improvement in terms of the increase in adenoma detection rate, the number of adenomas per colonoscopy, and actually a significant reduction in the number of missed polyps. And I think he referred to this, but really in 2023, there was a systematic review and meta-analysis that looked at 21 randomized control trials. And again, significant increase in adenoma detection rate, significant increase in the adenomas per colonoscopy, and a 55% relative reduction in the missed polyp rate. So it kind of begs the question, why am I even here? And should Dr. Torres just be kind of crowned the winner of this debate? But I like to kind of look at the facts and just, rather than philosophizing on potential benefits, I want to say what data is out there and what is that data showing? So I think there are some key limitations of some of these studies that we really need to kind of address. One, where are these studies being performed? And is it generalizable to the United States? It's hard to blind endoscopists to a bright green box or other kind of CAD-E systems. So just as a result of that, they're at risk for bias, and particularly this Hawthorne bias, where endoscopists might be a little bit more diligent when they know they're being watched. What types of polyps are we seeing? Are these high-risk advanced adenomas, these larger polyps or with high-risk features? Or are these small diminutive polyps that probably don't really have that big of an impact in terms of subsequent like colorectal cancer? Then finally, do these randomized control trials really reflect real-world experience, which is what we're practicing? We're practicing in a real-world experience. So in regards to the location, I would say at least the initial studies were predominantly performed in Asia and more specifically China. Now, there was a recent systematic review and meta-analysis that did some subgroup analysis where they looked at the improvement in the adenoma detection rate based off the location. And they saw that there was a significant increase, whether they occurred in Asia, seen on the left, or in North America or Europe. But what they found on the subgroup analysis was that improvement was more marked in Asia, in the studies conducted in Asia when compared to those conducted in North America and Europe, begging the question, is this dramatic increase in adenoma detection rate really reflective of what we would see in the United States? Additionally, how about the polyps that we're seeing? Based on 2 different systematic reviews and meta-analysis, there've actually been no improvement in the detection of these advanced adenomas with the implementation of CAD-E. And again, these advanced adenomas are the ones that are associated with post-colonoscopy colorectal cancer and a subsequent higher incidence in these advanced neoplasias. Now, do these randomized control trials really reflect the real-world experience? And I would say probably not. At least one of the first studies looking at this was a retrospective study out of a tertiary medical center in Israel. They looked at the 6-month period before and after the implementation of CAD-E at their institution. And interestingly, going from left to right, they actually saw a significant decrease in their polyp detection rate, a significant decrease in their adenoma detection rate, and a significant decrease in the advanced adenomas detected during this time period. More recently, there was actually a study out of Stanford that also looked to see what this one was out of, this wasn't my updated slide. So this one's actually out of MD Anderson. What I was referring to was one in Stanford, but this was one out of MD Anderson. Again, looking at that time period pre and after the implementation of their CAD-E system. And again, no improvement in their adenoma detection rate, no improvement in their adenomas per colonoscopy. And even when they went to did a subgroup analysis looking at those with low, middle, and kind of high adenoma detection rates, they saw no change in terms of their ADR during this period. And I will be honest, there was a recent systematic review and meta-analysis that did look at some of these more pragmatic or real-world studies. And on that, they did find a significant increase in the adenoma detection rate with CAD-E. And it went from a 35.8% to a whopping 36.3%. So although statistically significant, is it really clinically significant? And I would say that what Dr. Torres kind of pointed out with some of these New England Journal studies, that actually the top performing quintile in terms of adenoma detection rate, the lower end of that top quintile was actually 35%. So they're already high performers. So is there really that dramatic benefit from this increase in the adenoma detection rate? I would say probably not. Now, Dr. Torres might be thinking, well, these are all performed in academic centers. A lot of colonoscopies are performed in community practice. Do these actually reflect what's going on in the community? There's actually a randomized control trial that tried to address this, the AIC study that looked at 4 different community practices. And what the impact of was CAD-E on their colonoscopies. It was actually, the study ended early, in part based off some early analysis that showed no improvement in adenoma detection rate, no improvement in the number of adenomas per colonoscopy, no improvement in the sessile serrated lesion detection rate. The only thing that was significantly increased was the number of non-adenomatous and non-serrated polyps that were removed. So final take on CAD-E. Maybe we take a step back. I'll briefly talk about CAD-X. As Dr. Torres kind of mentioned, this essentially helps us aid in that optical diagnosis. Say, is this polyp neoplastic or non-neoplastic? Do I need to worry about it? And the goal of this is to hopefully kind of help with this resect and discard, where these small polyps can be resected, skip the pathologist, and just go right into the trash. And the hope would be this would save some costs on a global scale in terms of the use of the pathologist. The ASGE have made some kind of guideline recommendations where any of these optical diagnosis tools should ultimately result in a greater than 90% agreement with pathologists in terms of that final surveillance interval. One study I wanted to point out was a single center study that looked at 23 endoscopists, and they were given a picture of 60 different colorectal polyps. First, the endoscopists made a diagnosis on their own, and then they were given the CADX prediction and then could change their diagnosis. So there was a significant increase in accuracy from 69.3% to 76.6%, but well below that kind of 90% threshold. Interestingly enough, CADX was actually correct about 90% of the time, but I think that raises a really important question is this interaction between endoscopists and artificial intelligence. I think it's quite clear, even though the CADX outperformed endoscopists, the endoscopists didn't trust the artificial intelligence system. And I think that's an important thing when we're talking about implementing something on a kind of nationwide scale. So again, I might be wrong on this, but at least when I last looked, I didn't see any FDA approved available products in the United States. At least from my reading, I could not find one that distinguished between tubulovillous and villous adenomas, which make important distinctions in terms of surveillance intervals. And again, has not consistently met these requirements for a resect and discard technique. So in conclusion, the data on the randomized control trials for CADI, although exciting, hasn't really played out in these pragmatic or real world experiences. Also, CADI hasn't really demonstrated any improvement in the detection of these advanced adenomas, those that carry the highest risk for interval colorectal cancer. And then finally, CADX has not met these standards for the resect and discard. I want to leave with one image, and this was actually an AI generated image where I gave a prompt of two gastroenterologists debating and about artificial intelligence. And you look at the picture and it's kind of cool that AI could do that. But then you start looking at some of these things within the picture and you're like, something just seems a little off here. And I'd argue with, AI with colonoscopies right now, some things just seem a little off. Thank you.
All right, nicely done. Okay, we're in the home stretch here. We're going to do a pair of rebuttals now. So Dr. Torres will give a 2-minute rebuttal, and I will keep you to the 2 minutes. So as soon as the 2-minute mark hits, I will say stop, and we'll go then to a 2-minute rebuttal by Dr. Enck. So Alex, go for it. You can either, I guess, if you'd like to stay up there, if the mics are working well.
Seems like it.
Okay, perfect. Go for it.
Cool. All right. I guess I'll take you for a few points that I noted. One of them was, what kind of polyps are being found in these, colonoscopies that are increasing our adenoma rates or detection rates. I would say that, sure, it certainly could be that some of them are smaller diminutive adenomas of which the risk of interval cancer is kind of less clear. But I would, again, point you back to the Northwestern study that just came out in April of this year that showed an increase in the sessile serrated lesions that are found that have, again, a very high incidence of colorectal cancer and account for about 1/3 of those kind of cancers in themselves. And would also talk about the timing of the studies. A lot of these studies are from 2022 that are then leveraging technology from 2021 or 2020. And I would say that in the age of AI technology, just a year is a lifetime in terms of advancement. And these now we're here in 2024, midway through, and we're looking at AI from 2.5 years ago, almost 3 years ago. There's a very big difference. And I think the data point we signal points towards improvement in all the metrics we want, especially when they're done prospectively. I would point out the study that was used there that out of Israel, I think it was the Levy study that was included in one of the RCTs that I reviewed. If I recall correctly, I believe that was a major outlier of all the other 12 studies that were there and not in line with the rest of the data points. And then I think the final thing I would leave you with is if you were a patient, would you want your endoscopist to turn AI on? Just simply yes or no. And if it were me, I certainly would, because what's the harm? And I would say that AI, generally speaking, it requires very large data sets. And if we already see that there's a signal in this technology and that this is going to be the thing that's going to take us into the future, the more we adopt it, the greater that we use it, the more data, and greater learning, and the faster we can get to some of these more interesting and advances in technology.
All right, very good. 2 seconds to spare as well. All right. Tom.
All right. Kind of as I briefly mentioned in my discussion, I mean, I think one point that was made was this increase of 1% in terms of adenoma detection rate has this dramatic improvement. And I would say once we're kind of dealing with kind of here in the United States, where our average adenoma detection rate based off the GI Quick study was about 38%, that percent benefit really doesn't have as dramatic of an improvement in terms of reduction in the incidence of colorectal cancer or kind of post colonoscopy colorectal cancer. And that's kind of been true in that the New England Journal of Medicine study that was published that he referred to, as well as a subsequent JAMA article in 2022. He mentioned the business aspect. And I would say one important thing to note is, for example, with this resecting discard technique, many practices out in the community, they own their own pathologist and their review. And actually that's a revenue source. So right now, if that was adopted, there's nothing set up for those providers to get reimbursed. So that's actually lost revenue at this time for those providers, and particularly those owning their own practice. Right now, at least in the data studies I've seen, the use of CADI results in about a half-minute increase in their withdrawal time. So not too significant, but it's not improving the efficiency of that withdrawal time. And also it's an added cost for those providers. So right now there's no additional reimbursement for the use of artificial intelligence. So what's the financial incentive for those providers? And I would say right now there isn't a clear one. I think the other things is, well, what's the kind of clinical significance of this? Is this changing really the surveillance intervals? There was one study out of Europe that actually looked, now they're using the European societal guidelines, and the number of additional polyps picked up by the use of CADI, about 75% of them are actually diminutive polyps of less than 4%, and the surveillance interval only changed about 2% of patients. And I think right now we're at a point where we're already arguing, are we doing too many colonoscopies for these patients? Because really our focus should be on finding those advanced adenomas and finding a 4-millimeter polyp to increase our surveillance interval from 7 to 5 years. Probably isn't a big clinical significance.
All right, thank you. Just a round of applause for Dr. Enck and Dr. Torres. Nicely done. Okay, to wrap up their debate, by the way, I've never moderated a session while drinking a beer before, but it is enjoyable. I recommend it if you ever have the opportunity. Okay, so for the final part of this, we'll do the poll question again to see if there's been any change. So we'll bring up the poll question. There we go. So the same question, and we'll see if there are any changes. So again, how often do you think AI should be used during colonoscopy? Whenever possible or always, regularly, and infrequently? I hope someone remembered the numbers from earlier, but. Okay, well, it's interesting because I think we can actually compare if we just toggle back and forth at the bottom there between what happened earlier. If you can toggle at the bottom of the screen. So anyhow, most of you are still saying regularly. I don't think anyone said never initially. So, Tom. Congrats. You had 9% move into the special use only or never. Can we see the results from the beginning if we just toggle back? Does that still exist? Yeah. So we had 50% at regularly and 42% at whenever possible or always. And now a lot more in the infrequently or never. So if you move forward again, perfect. Okay, it's pretty close. It's pretty close. I think you're both winners. I think if we're using the delta, I think it might go to Tom. But regardless, nice job. I think that, like I said earlier, this is going to be a topic that is going to come up repeatedly. Just generally the use of artificial intelligence, and so we wanted to at least include that today. So thank you again. That concludes the sessions, and we'll wrap up now just with some closing remarks. Dr. DeLay and Dr. Chang will join me up here as well while we pull up these slides. And then we will conclude by drawing 10 $100 gift cards for those of you who are still here. So want to just start by saying thank you to all of you for coming. Thank you to the faculty. Some of you are still here for presenting. We really appreciate kind of everybody's involvement here, from you as the attendees to the faculty, speakers, and certainly to the sponsors as well, whom we'll name shortly. We don't have an exact date for next year's course, but it will be roughly 1 year from now, August 2025, the 12th annual Rocky Mountain Highlights Conference, which will be I think in this room, as long as we can reserve it. So we look forward to that. I also want to, we're going to highlight a few other save the dates. One is a hepatology and liver transplant webinar series that I'm the course director for as well. Nope. It's runs in the family. This is a webinar series we started a couple of years ago, and this allows for kind of an update every few months on basically updates and common topics in hepatology and liver transplant. So we've already had 3 of these talks this year, so you can see that those dates have passed. But the next one is Wednesday, September 18th, Updates in Management of Alcohol-Associated Liver Disease by my colleague, J.P. Norvell. Then our clinical pharmacist in our clinic, Robin Bricker-Ford, is going to give a talk on updates in viral hepatitis in the outpatient setting in November. You can register at that QR code, but you can also just Google University of Colorado webinar series and it will come up. We'll have another series next year. I do want to just mention as well, in addition to the fact that this offers free CME, is that all the videos from the past webinars from this year, last year, the year before are all on the website, so you can go back and watch prior talks if you would like.
All right, we also have the 6th annual Dennis Onnen Lectureship. This is September 26th of this year. And it'll be Bridging the Gap in Precision Medicine and Healthcare Equity, and our speaker will be Sonia Cooper, so don't miss that. The 19th Rocky Mountain Interventional Endoscopy course, very popular course, also happening in September of 2025, September 25th through 27th. So mark your calendars for that. We appreciate all of our supporters. I'm going to have Debbie read our exhibitors here.
Thank you again for educational grants from Janssen and Olympus, as well as our gold exhibitor, Takeda, along with our silver exhibitor, Olympus America, our bronze exhibitors, including AbbVie Digestive, AbbVie Hepatology, Braintree, a part of Sabella Pharma, Cook Medical, Exelixis, Gilead Sciences Hepatitis B, Intercept Pharmaceuticals, Magical Pharmaceuticals, Microtech Endoscopy Interscope, Avesco Endoscopy, Fathom Pharmaceuticals, Sanofi, AbbVie, GI Care, Ardelyx, Bristol Myers Squibb, Castle Biosciences, Fujifilm Healthcare Americas, Gilead Sciences Liver Disease, Janssen, Mallinckrodt Pharmaceuticals, Medtronic, Orplan, Pfizer, and Salix Pharmaceuticals. And please give us feedback. Here's our email addresses. And then once again, as mentioned in the beginning, make sure you get your education credit. Don't forget, reach out to Christy Click. You can see your email address here if you have any questions or issues. Here again is information about the CME credit and the ABIM MOC points. And then here is the QR code. Sorry about that.
Okay, and this is also the QR code for the NCPD nursing contact hours.